Good morning, everyone. Let's all crack NEET PG exams with Unacademy, where you have top educators, quality content, and a great learning experience. So, guys, let's crack NEET PG. Okay, a little about me. I've done my MBBS from Father Muller Medical College, Mangalore. I've done my MD in Anesthesia from the same college. I have two publications and one paper presentation in the field of anesthesiology, and I have been working and teaching in Bangalore for the past 2.5 years. So our topic for today, while we are going to crack NEET PG together, is neuromuscular blocking drugs. I have taken one part on these drugs already. This is the second part, which involves the non-depolarizing muscle relaxants. So the first part was actually the depolarizing muscle relaxants, which was your succinylcholine. That is the only drug which we are currently using in the field of anesthesia. And this is the second part, that is a non-depolarizing muscle relaxants. I'll be giving you a brief overview about the previous class too in this class. So guys, I will be telling you all a little on how to crack NEET PG. How it is possible to crack, why it is possible rather to crack NEET PG with Unacademy. So Unacademy is India's largest learning platform. You can get one of India's largest learning platform. You can get plus subscription and access unlimited live and recorded courses from India's best educators. So guys, why delay? Hurry right now. Get your subscriptions. So what will you get out of Unacademy? So you have your daily live classes where you can chat with your educator, engage in discussions, ask your doubts, clear your doubts. There will be answer polls, and all this is while your class is going on. So basically, while you attend these coaching institutes and all that, you waste a lot of time traveling firstly to these it does take time to travel, get there, energy also. So you're wasting a lot of that to get there. Then by the time you settle down in the class, these are huge classes where there are over like 100, 200 students. I don't think there are any small classes. But so on Unacademy, it's kind of a one-to-one. You can chat with your educator, send your doubts to your educator. They will clear your doubts at any particular time. You can ask your doubts during the session. In a coaching class, it's a little difficult because there are so many people sitting. It's a little difficult for the educator there also to clear so many students' doubts at that point. But here, since it is side by side, so as we're teaching, we can clear your doubts. We keep sometimes at the end of the session to clear your doubts. It is all ongoing. It is like a one-to-one session for you all. These courses are structured courses. Okay, these are all in line with your exam syllabus and help you best prepare for it. So these courses are all inline courses and help you prepare best for your exam syllabus. They're all structured. They have been everything is well prepared, well thought of in link with NEET PG. Now you have your live tests and quizzes which evaluate your preparation. Okay, we evaluate your preparation with our regular mock tests, quizzes, and hence get you, as well as y'all can get a detailed analysis on your performance. So there are regular tests. So in between classes on a particular topic, we will be giving you all quizzes, we'll be giving you all tests. There will be polls where you can know how you all are doing. So all this helps you. So it's all structured. So you're actually learning, you're revising, and we are helping you all with that. You have an unlimited access. One subscription gets you access to all our live and recorded courses to watch from the comfort of your devices and wherever you are. So it is one subscription which gives you ability to view all the live classes, the recorded classes, and you can watch it from the comfort of your device, whatever device you are using, and from wherever you are, whether you're at home or you're in a hostel or you're traveling. As long as you all have internet, you all can watch it. And of course, there are the recorded classes too, like I said. So These are some of our top educators. Dr. Nikita Nanwani, she's a NEET PG mentor for radiology as well as mnemonics and concept focusing on must-know topics encompassing all subjects. This is Dr. Muhammad Azam. He teaches anatomy and 2 more subjects. Devish Mishra, MBBS MD from AIMS. Dr. Preeti Sharma. These are all top educators. These are the courses offered. As you can see, there are 19 courses. And these various classes, there are various courses in each subject which you all can go through. You all can access at any point of time whenever you all want from your devices. All structured courses which will help you all by top instructors. These are some of the ongoing courses on our platform. As you can see, neurophysiology, the motor system, pathology, respiratory system, larynx, your cardiovascular thoracic surgery, course on GI surgery. So now coming to your subscriptions. As you can see, there are 5 types of subscriptions, but I would highly recommend the 12-month and the 24-month subscription, guys. So the NEET PG, it encompasses 19 subjects. These subjects are vast subjects. It is not possible for anybody to complete 19 subjects, such big medical topics, in 6 months, 3 months, or even a month. So it doesn't make sense to try to do it in that time. So I would suggest that you all go for the 12-month subscription because it gives you all time to prepare. Like I said, structured courses, it helps you all prepare with us. We will help you all prepare. And of course, the economical part of it is, with 12 months is just one subscription. See, after 6 months, once your subscription gets over, you have to subscribe again, right? But with the 12-month subscription, it's a 1-year subscription. You have paid once for all and you're reaping the benefits of it. So if you use my code, as you can see at the bottom of the subscription page, it's SASHA, and you can avail a 10% discount. Okay, so guys, subscribe quickly. Okay, use my code SASHA and you can get your 10% discount and subscribe. Then the 24-month, again, it is more economical and more practical as you have more time to prepare. So if you feel you need 24 months to prepare, go ahead, guys. There is nothing wrong. It is ideal. It is good to take your time, do your subjects and prepare. So 12-month and 24-month is what I recommend for you all. I would definitely take it, and I did take it that time to prepare. So please use my code SASHA and do subscribe. Okay, now let's come to our topic for the day. That is our neuromuscular blocking drugs. So by definition, neuromuscular blocking drugs principally act by interrupting the transmission of nerve impulses at the neuromuscular junction. Just a sec, guys, I'm sorry. Yeah, okay, fine. So, neuromuscular drugs, sorry guys, there was some technical issue. So they principally act by interrupting the transmission of nerve impulses at the neuromuscular junction. So at the neuromuscular junction, you have your nerve. This is your nerve. Then you have your muscle membrane. This is your muscle, right? This is your nerve. This is your muscle. So the neuromuscular drugs act principally by interrupting the transmission of nerve impulses at this junction. So acetylcholine is stored in tiny vesicles over here at the nerve terminal, and whenever there is a impulse, that is whenever there is a stimulation of the nerve, electrical stimulation of the nerve, it causes the calcium channels which are present on the nerve to open. So the calcium channels open, there is an influx of calcium. So whenever the calcium enters, it causes the release of this acetylcholine from these vesicles. Now when this acetylcholine is released from these vesicles, it goes and binds to the acetylcholine receptors which are located on the muscle. Now the muscle is thrown into many folds at the motor end plate. So this is known as your, this entire thing is known as your motor end plate. Okay, actually the muscle, this part is actually known as your motor end plate, but this entire thing, so where the nerve, where it synapses with your muscle, this particular portion is thrown into many folds. This increases the surface area of contact, and at the folds, at the shoulder of these folds are located your acetylcholine receptors. Okay, I'm sorry. The acetylcholine receptors are located here, and further down here in within the cleft is located your is the sodium channels. Okay, I'm sorry. So further down is your sodium channels. So the acetylcholine gets released from the nerve. It comes and binds to these acetylcholine receptors which are located here, and it causes a conformational change in the receptor which leads to opening of ion channels. So when those ion channels open, sodium and calcium will move in and potassium will move out. Okay, so and this leads to a depolarization. It creates a threshold potential at the motor end plate. This threshold potential causes excitation of the muscle, which leads to muscle contraction. Okay, so that will lead to your muscle contracting. Now, the acetylcholine receptor per se, okay, your acetylcholine receptor is made up of 5 subunits. Okay, 2 alpha, 1 beta, okay, 1 delta, okay, and 1 epsilon subunit. Okay, so this is what your mature receptor is made of. Now acetylcholine has to bind to the two alpha receptors. It has to bind for muscle contraction to take place. So acetylcholine is released whenever there is an electrical impulse. It has to bind to both the alpha receptors on the acetylcholine receptor. Then only conformational change will occur in the acetylcholine receptor, which leads to opening of the receptor channel, which leads to ion fluxes, which causes depolarization of the, it causes a threshold potential leading to depolarization, leading to muscle contraction. So this is a brief overview of neuromuscular transmission. Okay, now how do these drugs act? They act by interrupting this transmission of nerve impulses, hence they prevent muscle contraction. So the classification of neuromuscular drugs, it has been classified as based on the duration of action. They have been classified as depolarizers and non-depolarizers, right? So your depolarizers mimic the action of acetylcholine, and the non-depolarizers are basically, they are known as non-competitive antagonists. So they are non-competitive antagonists, right? So depolarizers, basically what is in use right now in anesthesia is your succinylcholine, also known as succinylcholine. Now, succinylcholine, like in my previous class, it acts by, it is an agonist. It has an agonistic action. Okay, that is, it mimics acetylcholine. So it binds to the two alpha subreceptors, and it binds to the two alpha receptors on the acetylcholine molecule, and it causes depolarization initially, which leads to muscle contraction. Okay, but it causes a sustained depolarization. Okay, the depolarization is sustained. So this what happens is, acetylcholine gets degraded by acetylcholine esterase, and hence the action is terminated, and the nerve, it is not, the muscle, the receptors return to the resting phase, and hence muscle contraction stops. But with succinylcholine, the receptors get blocked in something known as the inactivated state. As a result, there is no depolarization occurring, as well as the receptors are not in the resting phase. So fresh depolarization also cannot occur. So that is how. So succinylcholine, by two mechanisms this occurs. It blocks the nerve, and it blocks the, I'm sorry. There are two phases: phase one block and phase two block. Phase one block is, like I said, it blocks the sodium channels in the inactive phase, preventing muscle contraction. And phase two block is generally, it is seen when you give a second dose of succinylcholine, or if there is any other additive factors. Basically, that action is due to action of succinylcholine on the presynaptic acetylcholine receptor. So succinylcholine basically acts on the postsynaptic receptors that are located on the muscle. Okay, for phase 2 block to occur, it acts on the presynaptic, not on the presynaptic, which is located on the nerve, which is located on the nerve. So that is your briefly about succinylcholine. It is used for, it's basically a very short duration of action. It has a very short duration of action. Action is terminated very quickly. So it is used for tracheal intubations mostly, and for short procedures. Adverse effects are, it can cause fasciculations because of the initial contraction. It can lead to rise in intraocular pressure, intragastric pressure, intracranial pressure. Hence, it is avoided in trauma, head injury, and ocular injury patients. Now, coming to the non-depolarizers, that was briefly about the agonistic neuromuscular blocking drug. Now, the non-depolarizer, which is in detail, and I've divided it into two classes. So, the classification of non-depolarizing muscle relaxant is by the chemical structure. So, they can be classified as steroidal compounds, benzyl isoquinoline compounds, of phenolic ether like galamine. Okay, so now your steroidal compounds are your pancuronium, rocuronium, becuronium, rapacuronium, pipacuronium. Rapacuronium is not in use. What is most commonly used is your rocuronium, becuronium, pancuronium. That is used, not commonly used, but I'll tell you all what is commonly used and all usually, but these are in the market. Now your benzyl isoquinoline compounds is your D-tubercurin, atracurium, metacurium, cisatracurium, doxacurium, mivacurium. Phenolic ether is galamine, and your strychnose alkaloid, alkuronium. Now, classification based on the duration of action. That was based on the chemical composition. This is based on your duration of action. Now, your long acting, that is long acting more than 1 hour. So, basically, we give this, these are muscle relaxants, are basically to help aid tracheal intubation, because we need the patient to be paralyzed so that we can secure the airway. Otherwise, the vocal cords keep moving and it is traumatic to the vocal cords. The patient can go into laryngospasm, because if the cords are moving and you are trying to pass a endotracheal tube through them. So we need complete muscle relaxation. The surgeon needs complete muscle relaxation while he is operating for a clear field of surgery, so that no bowel is pushing down when he's operating. The field should be relaxed for him to so that he can access the structures while operating. So an initial loading dose is given, followed by maintenance doses of these non-depolarizing muscle relaxants. Choline, usually a single dose is given. Repetitive doses are not given, as it leads to a phase 2 block and causes a lot of other complications associated with choline, like I have told you all about in my previous class. So these are given as a single loading dose, followed by maintenance doses. I will be coming to that later. So duration of action, that is after a loading dose, these are long acting, usually act for 1 hour, which are your D-tubercularian, metacurium, doxycurium, pancuronium, alcuronium, galantamine, and pipocuronium. Out of these, this is what we will deal with in detail, not the rest. I will tell you all about the rest briefly, some of these like DTC, galamine, but this is what we will deal with in detail. Relaxants of intermediate duration, 30 to 60 minutes, which is your vecuronium, atracurium, rocuronium, cisatracurium. We will be dealing with all these, as all these are in use and these are the most popular actually in use. Then your short acting are your mivacurium, 12 to 20 minutes, and your rapacuronium. Rapacuronium is no longer in the market because it causes severe bronchospasm. I will be coming to that too. And short acting, less than 10 minutes, which again not in use. Now your mechanism of action of non-depolarizing neuromuscular blocking agents. So like I said, depolarizing agent succinylcholine, your depolarizing muscle relaxant, succinylcholine, acts as a acetylcholine receptor agonist. I told you all previously. Whereas, so it acts as basically as a agonist. Whereas non-depolarizing relaxant function as competitive agonist. So competitive agonist is, it competes with acetylcholine to bind to the receptor. So there is a constant competition of this non-depolarizing muscle relaxant to bind to the receptor, and it competes with acetylcholine, hence competitive antagonist. So non-depolarizing muscle relaxants bind acetylcholine receptors, but they are incapable of inducing the conformation change that is necessary for ion channel opening. So like I told you all earlier, acetylcholine has to bind to the 2 alpha receptors. It has to bind to 2 alpha receptors to cause conformational change in the receptor, which causes the opening of the ion channel, leading to influxes of the ions. As a result of these influxes, threshold potential is generated, end plate potential develops, muscle depolarization occurs, muscle contraction occurs, right? But because as here it is when the non-depolarizing muscle relaxant binds to acetylcholine, it is incapable of inducing this conformation change. Okay, so it is not an agonist, it is an antagonist. So succinylcholine is an agonist. So succinylcholine is very similar to acetylcholine, right? The structure. So it causes a conformational change necessary to open the ion channel. It opens the ion channel and causes initial contraction. But because of the sustained depolarization, there is neuromuscular blockade. But with these non-depolarizing agents, it does not cause any. It competes with acetylcholine firstly to bind to the receptor, and it does not induce a conformational change. Because acetylcholine is prevented from binding to the receptors, and there is no end plate potential develops. There is no acetylcholine binding, no conformational change, no opening of the receptor, no end plate, no muscle contraction. So neuromuscular blockade can occur if only one, this is important guys, only one alpha subunit is blocked. Now, I have been stressing that both alpha subunits have to be blocked by acetylcholine for depolarization and muscle contraction to occur. But when a competitive antagonist like a non-depolarizing muscle relaxant is present, it needs to bind to only one alpha receptor to cause block in transmission. So it is like it is a mathematical relationship. Uh, you can say, okay, I'll take the relation of 4:2. Okay, so if two receptors are blocked by these depolarizing muscle, um, sorry, non-depolarizing muscle relaxants, you will need 4 molecules of acetylcholine to overcome this. Remember, it is a competition, right? It is a competitive antagonist. So even acetylcholine competes with that. Yeah, even acetylcholine is competing with this. So if two receptors are occupied by this neuromuscular blocking drug, then you need 4 molecules of acetylcholine to overcome this blockade. Now, sequence of muscle blockade. So the first muscle to be blocked by both depolarizing and non-depolarizing muscles relaxants, are the central muscles, then the peripheral muscles. So the sequence of blockade, as you can see, is your face, jaw, pharynx, larynx, muscles of respiration, that is basically your diaphragm, your trunk muscles, and your limb muscles. Recovery also occurs in this order. Okay, now this is important. Now, actually, when you go to see according to the potency of the drug, so potency of the drug is amount of drug that is required. I'm not telling you the physiological this thing that you all have to be aware of, but yeah. So it is the amount of drug that is required to bring about a reaction which has been compared to controls, right? So the potency in case of neuromuscular blocking drugs, it is paralysis basically. So the time to paralysis, so the dose of the drug which will lead to paralysis in 50% of the patients is basically gives you the potency. So the potency of a drug of based on the potency of the drug, actually the muscles of the larynx and the diaphragm, yeah, these two are actually resistant. Okay, these two are actually resistant to they require 1.5 to 2 times the dose to be of the muscle relaxant to be blocked, okay, as compared to the adductor policies. Okay, now your adductor policies, if you go by the potency of the drug, it gets blocked more quickly than your muscles of the larynx and the diaphragm. So your muscles of the larynx and diaphragm actually require 1.5 to 2 times more the dose of the muscle relaxant to get blocked. But in actually the as you can see, like I have just said, according to the sequential blockade, your larynx and your diaphragm get blocked much before your limb muscles. The adductor pollicis is basically your limb muscle, your thumb muscle. So it gets blocked much before than the limb muscle. Why? So it is said that the plasma equilibration between the equilibration of the blood in the plasma and the site is quicker in these muscles. So basically, it is the circulation. Yeah. So these muscles are better innervated. Your diaphragm and your larynx, the circulation is important. The blood flow is important. They are more vascular than your adductor pollicis. So basically, because the circulation time is quicker, the drug is reaching here quicker, so they are paralyzed quicker. So it depends, the paralysis depends on the site equilibration, that is basically on the circulation, not on the potency of the drug. Okay, Now, even studies have even shown that during recovery, only like maybe about 18% of the receptors in the larynx and have to be, I'm sorry, 18% of the receptors in the diaphragm need to be available, whereas in the limb, 29% of the receptors have to be free for again neuromuscular contraction to start. This is during recovery. Studies have shown this. So basically, what can also is hypothesized is that the larynx and the diaphragm have more number of receptors as compared to they have more number of receptors as compared to the limb muscles. That plus circulation, like I said previously, circulation. So the two main things that which lead to this sequential is your circulation, the circulation which is more in the larynx and the diaphragm, and the number of receptors. Yeah, so basically the number of receptors and the circulation. Now the dose of non-depolarizing muscle relaxants, like I said, needed to block the diaphragm and the muscles of the larynx is 1.5 to 2 times that of the adductor pollicis. Like I have already told you, I just explained to you all that it is 1.5 times that of the adductor pollicis, depending on the, this is if you go to see, depending on the potency of the drug, this. Okay, but in spite of this blockade, it is faster at the diaphragm and laryngeal adductors because of rapid equilibration between plasma and effect and the effect compartment. This is where your circulation, your circulation comes into play. Okay. Now, hence the muscle blood flow, like I said, the circulation rather than the drug intrinsic potency is more important in determining onset and offset time. So this is important to remember, that the sequence of blockade is important for you all to remember. What is the sequence of blockade occurring? That is your the sequence of blockade, that is your face, jaw, pharynx, larynx, respirator muscles, trunk muscles, limb muscles, that, and the recovery is also in the same order. So the pattern of blockade, the onset, the onset, depth and speed of recovery in the corrugator supercilii. Yeah, this is another important factor for you guys. The corrugator supercilii is very similar to that in the larynx and the diaphragm and the abdominal muscles. So the pattern, so basically this is when, so for neuromuscular monitoring, which is again my next topic after I finish my 2 classes on this. So neuromuscular monitoring is very, very important to know the depth of block and to know when to reverse a patient out of this blockade, because if you bring the patient out of the blockade before some amount of neuromuscular junction function has developed, there can be residual paralysis, which is very dangerous as it can lead to aspiration, because the tone of the pharyngeal muscles, the esophageal tone is not there, so it can lead to aspiration and of course death. So the corrugator supercilii is, since it is very similar to the larynx and pharynx in the pattern of blockade, that is your onset, depth and recovery. So by monitoring this pattern of muscle, one can predict the quality of tracheal intubating conditions. So even the conditions for tracheal intubation have to be a deep blockade. So the blockade has to be deep, because if in a shallow plane of neuromuscular blockade, if you try to intubate, again I said that the muscles, the pharyngeal muscles, the laryngeal adductors will not be paralyzed. There will be motion, there will be motility, and this can lead to firstly trauma, because you're pushing a tube through, as well as it can trigger laryngospasm. So, non-depolarizing neuromuscular block. What are the characteristics? So, it is characterized by, as you can see, a decrease in twitch sensation, tension, fade during repetitive stimulation, and post-tetanic potentiation. Now, these three are basically neuromuscular monitoring. These are the characteristics of a non-depolarizing neuromuscular block. I will be teaching these in detail in my coming classes. So basically, a muscle basically is stimulated by a nerve stimulator, which is a device, okay, which has electrodes are connected on the muscle. That is, this is to detect the depth of block. So there are the electrodes will be connected from this nerve stimulator to the muscle, and whenever an electrical stimulus will be given, there will be a button here to give an electrical stimulus, and the recordings will be seen over here. The recordings are these, okay, these are your recordings. So twitch depression. So basically, whenever there is a recording, occurring, that is, whenever there is a stimulus, single twitch, one stimulus will be given of a particular current. So whenever there is a blockade, neuromuscular blocking drug has been given, a twitch depression, so you will see it as, this will be a normal response to a single twitch, each twitch, and but in after neuromuscular blocking drug, there will be a decrease in response. Both will be of the same amplitude, but these two will be of the same amplitude, but as compared to control, there will be a decrease in response. This occurs because of block of the postsynaptic nicotinic acetylcholine receptors. Okay, so the postsynaptic, which are located on the muscle membrane. Now the tetanic or the train of four fate, TOF is a train of four fate, results from, so train of four is 4 stimulations are given. 1, 2, sorry, just a sec guys, this thing is stuck, yeah. So 1, 2, 3, 4. 4 stimulations will be given, and you will see a fade. After neuromuscular blocking drug, there will be a fade like this. So this decreasing trend, can you see this decreasing trend? So there will be a fade in the pattern of neuromuscular block. So this occurs due to presynaptic. This is blocking of the neuromuscular, blocking of the presynaptic, which is located on the nerve, blocking of the nicotinic acetylcholine receptors on the presynaptic nerve terminal. Okay, so neuromuscular drugs, they prevent acetylcholine from being available for muscle contraction by blocking the pre and the postsynaptic receptors, and hence the released acetylcholine will not match the demand, because there is less acetylcholine. The released acetylcholine, it will not match the demand because the receptors are occupied. So for muscle contraction, a particular number of receptors have to be occupied before muscle contraction occurs. But because this is not happening, a fade is observed in response to stimulation. Now pharmacokinetics, they are highly ionized, water soluble at physiological pH. Now highly ionized in the sense, highly ionized because these are quaternary ammonium compounds. As you can see here, these are quaternary ammonium compounds. Yeah. So to the quaternary amine, basically they can bind hydroxy, methoxy, and ester groups can bind. Okay, because of this, it makes it binding to the quaternary amine of these hydroxy, methoxy and ester groups, makes this compound highly water soluble at a physiological pH. Okay, they are hydrophilic and hence they do not cross the blood-brain barrier as well as the placenta. So they are not lipophilic, they are hydrophilic and hence they cannot cross the blood-brain and your placenta except galamine. Please remember this, except galamine. Galamine can cross the blood-brain barrier and the placenta because it is lipophilic also. Okay, so except galamine, hence obviously it is not used. So hydrophilic and highly water soluble, cannot cross blood-brain barrier and placenta. Hydrophilic because the quaternary ammonium compound can bind to hydroxy, methoxy or ester groups, which make it water soluble. And most of the drugs undergo renal and hepatic elimination. Now the effective dose ED95, effective dose 95. So the effective dose of a drug in 95% of the individuals, this is the effective dose of the drug in 95% of the individuals. So for neuromuscular blockers, one often specifies the dose that produces 95% twitch depression in 50% of the individuals. Okay, it denotes the potency, like I was saying, a particular response that is recorded in 50% of the individuals. In this case, the response is decrease in twitch depression. I told you neuromuscular monitoring, electrical stimulus is given and that electrical stimulus will elicit a twitch in the muscle. So in 50% of the patients where this twitch, the amount of drug that is bringing about this twitch is known as the potency of the drug, and it is known as the effective dose of the drug in 95% of the individuals. Excuse me. Now dosage, coming to the dosage. Now the speed of onset is inversely proportional to the potency of the non-depolarizing muscle relaxant. So that is the speed of onset is inversely proportional to the potency. So higher potent drugs, that is more potency of the drug, that is higher concentration, more amount of drug, okay, the more amount of drug, quicker the onset of action. Okay, less amount of drug, lesser concentration of the drug, longer the onset of action. Got it? So the speed of onset is inversely proportional to the potency of the non-depolarizing muscle relaxant. So a high ED95, that is a low potency drug. Okay. So a low potency drug will have a rapid onset of effect and vice versa. So basically a high ED95 is more amount of drug is required to bring about a particular effect. So the effective dose to bring about 95% of depression of twitch is more. So low potency drug, but it will have a rapid onset. Why does this occur? So it is based on the basis of density of the receptors. So for neuromuscular transmission to take place, for blockade to occur, irrespective of the potency, a critical number of receptors have to be blocked for the blockade to occur. So a particular number has to be blocked for neurotransmission to be stopped. So when you give a low potency drug, you are giving more of the compound, right? There is more drug. Even though the potency is low, the potency is low, the amount of drug is more. That is why it is known as a low potency, because more drug is required to bring about a particular effect. So the potency of the drug is low, but the concentration, the number of molecules of the drug is more. So more receptors will be occupied, so the onset of action is quicker. Whereas with a high potency drug, there are very few molecules. So the number of receptors that have to be occupied to surely bring about blockade of transmission, it will take slightly longer time, and hence it takes some time for onset of action. So the more potent compound like cis-atracurium, that is very little amount of the drug has to be given for action, it has the slowest onset. Whereas the least potent compound, rocuronium, has the fastest onset. So basically, like I told you, in anesthesia, an initial dose is given to secure the airway, followed by that to maintain relaxation during the rest of the surgery. Maintenance doses are given. So twice the effective dose ED95. So twice the ED95 is the dose used to facilitate tracheal intubation. So twice the ED95, this is important, is the dose used to facilitate tracheal intubation. So when doses lower than those needed to cause 100% blockade are given, the time to maximum effect is a function of the neuromuscular blocking drug and the blood flow to the muscle. Okay, so that is when a lower dose is given to cause blockade. The effect of when the lower dose is given, that is a dose lower than that which is causing 100% blockade. So the time to the maximum effect, that is to paralysis, is a function of the neuromuscular blocking drug and the blood flow to that particular muscle. However, when a dose that is causing 100% blockade is given, that is a complete dose which will cause 100% blockade is given, it does not depend on the blood flow, it just depends on the drug and basically the potency of the drug. It depends on the drug, because only the huge amount of the drug is given, it will just go bind to the receptors. It does not depend on the blood flow. Now maintenance doses are 1/10 in case of long acting, that is like your pancuronium, and 1/4 in case of your intermediate and your short acting, that is your atracurium, vacuronium, rocuronium. So in case of long acting, you give 1/10 of the intubating dose, and in case of intermediate and short acting, you give 1/4 of the intubating dose. Now, why potent neuromuscular blocking drugs has a slower onset of action, and what is a priming dose? So the general rule is, like I just explained to you, the more potent the non-depolarizing muscle relaxant, slower is the speed of onset, because more the number of molecules available at the receptor, more rapid is the onset. That is a lower potency drug because there are more molecules. Lesser the number of molecules, that is a higher potency drug, they will be available at the receptor to get a response in case of a potent drug. So in case of a potent drug, there will be less number of molecules at the receptor, so the time to onset will be longer. Now what is a priming dose? So priming doses, these are doses which are generally given to facilitate, that is to shorten the, so basically before intubation, when you give, the time to peak effect is usually about 3 minutes. So after giving these intermediate acting drugs, you have to, non-depolarizing muscle relaxant, generally you have to wait for a period of 3 minutes before you can secure the airway. So to shorten this time, that is the amount of time that it takes to reach the receptors. To shorten this time, this is a method known as priming. That is, you give 10 to 20% of the usual intubating dose is usually given about 3 to 5 minutes before induction. Okay, whatever your intubating dose is, you will give around 10 to 20% of that intubating dose. After about 3 to 5 minutes, you give the remaining dose. So this basically shortens your time to intubation to about 90 seconds, from 3 minutes to about 90 seconds. So after this, the complete dose is given within 30, you have to give the complete dose within 30 to 60 seconds, and overall the duration of shortening is only 30 to 60 seconds. So you can secure the airway after 90 seconds after this method as compared to 3 minutes. But the thing is, it has not, the problem with this is it is contraindicated where it is a difficult airway, or in cases where the patient is highly sensitive to neuromuscular blocking drugs like in myasthenia gravis. And also it does not provide, it is said that it does not provide that complete relaxation as compared to succinylcholine. So succinylcholine acts immediately within 60 seconds, and you can secure your airway within 60 seconds. But this the relaxation is not always complete. Plus what happens is the patient feels very uncomfortable because you haven't yet completely given the patient, if they are highly sensitive, they can even that little 10 to 20% dose, it the feeling that you cannot breathe, your muscles are paralyzed, not completely paralyzed, so which again can lead to aspiration and airway complications. So large dose regimen for rapid tracheal intubation when intubation is needed in less than 90 seconds. So zero point 0.6, so when intubation is needed in less than 90 seconds, generally rocuronium is used. And the dose of rocuronium which can be used for this, other than succinylcholine, this is another drug which can be used, that is your rocuronium. This is important for rapid tracheal intubation. Rocuronium is important, and the dose is 0.6 mg per kg, twice the effective dose, to 1.2 milligram per kg. It shortens the onset time from 89 to 55 seconds, but doubles the duration of action. But that is okay as you secure the airway, and anyways you waiting, it is basically, once the airway is secure, you can always wait for that duration of action to die down. So the intubating for rapid intubation, this is the intubating dose for rocuronium, 1.2 milligram per kg. Now metabolism and elimination. So these compounds have a high degree of water solubility with very little lipid solubility, which enables easy elimination by the urine by only glomerular filtration. There is no tubular reabsorption or anything occurring. It is only purely glomerular filtration, which is around 1 to 2 ml per kg per minute. Now coming to the metabolism of the long-acting neuromuscular blocking drugs. So they are cleared largely by the kidney. This is basically, I'm talking about pancuronium. Okay. It is cleared largely by the kidney. 15-20% is deacetylated in the liver. It is deacylated at the 3rd and the 17th position. Now 3 metabolites. It has 3 metabolites. 3 metabolites are produced. Yeah, and the 2 metabolites are inactive, but the 3-hydroxy metabolite is the most potent of these metabolites. Its potency is half that of pancuronium, but it undergoes the similar pharmacokinetics and the actions as pancuronium. I'll be discussing pancuronium later, but this is the metabolism, and this metabolite is excreted in kidney. So basically, majority of the excretion of pancuronium is by the kidney, only 15 to 20% by the liver. And the clearance, and this is the active metabolite 3-hydroxy, and it is half as potent, but it undergoes the same action and pharmacokinetics as pancuronium, excreted by the kidney. Hence, in renal diseases, clearance of this pancuronium and the metabolite is delayed and the duration of action is prolonged. So the dosage has to be adjusted. Now the intermediate acting neuromuscular blocking drugs, that is your vecuronium. So it is more lipid soluble. So in the quaternary, basically I told you it's the quaternary amines, where the quaternary group is replaced by a methyl group, a hydroxy group, which makes it water soluble. But this methyl group is not there in vecuronium, so it makes it more lipid soluble, and vecuronium undergoes more metabolism than pancuronium as such, as you will see. So 12% by the liver microsomal enzymes, which produces a metabolite which is the active metabolite which is des-acetylvecuronium, 30 to 40% in the bile as the parent compound, and 25% as renal excretion. These values are important. So 12% by liver enzymes, 30 to 40% by bile, 25% by renal excretion. And the metabolite des-acetylvecuronium, it has a much slower plasma clearance, longer duration of action, and renal clearance. Hence, in ICU patients, when infusions of this vecuronium are given, it can, in patients with renal disease, there will be a longer duration of action of this drug because of this metabolite des-acetylvecuronium. Now, rocuronium, it is cleared primarily by the liver, and only 10% is excreted in the urine. Now coming to atracurium and cisatracurium. So atracurium undergoes Hoffman's elimination, right? This is the only one which is independent of any organ dependent metabolism. It undergoes Hoffman's, which is purely a chemical method of metabolism, right? So in this, Hoffman's elimination is pH and temperature dependent. It undergoes Hoffman elimination as well as this ester hydrolysis. Both are important. This is atracurium. So Hoffman's elimination is basically a chemical degradation of the quaternary ammonium compound to a tertiary amine, that is laudanocin, and a monoquaternary acrylate. So because this degradation, chemical degradation, occurs because of the two carbon bonds that are present next to the amine group. On the atracurium structure, there are two carbon bonds that are present near the quaternary amine group. The quaternary amine group, these bonds can be broken, leading to a tertiary amine, okay, which is laudanocin. And because of the nature of this bond, two carbon atoms binding to the quaternary ammonium, it can be cleaved easily, leading to a tertiary amine laudanocin and a monoquaternary acrylate, which are the metabolites. This laudanocin has CNS stimulating property, but it is not seen. The side effects of laudanocin are not seen, but it is a metabolite of atracurium, which is asked quite often in the exams. But the CNS stimulating properties are not seen, as the concentration required to cause the CNS stimulating properties are not seen in ICU or operation theatre patients, even after a prolonged duration of anesthesia and relaxation. Now coming to cisatracurium, 77% is by Hoffman elimination, but there is no ester hydrolysis. So there is no ester hydrolysis. Atracurium has ester hydrolysis. 23%, this has organ dependent elimination. Out of the 23%, 16% is by renal. Now coming to the short acting neuromuscular blocking drug, that is your mivacurium. Butyrylcholine esterase, it is degraded by butyrylcholine esterase to a monoester and an amino alcohol, which is excreted in bile and urine. So this is the only neuromuscular non-depolarizing neuromuscular drug that is degraded by butyrylcholine esterase. So depolarizing relaxant succinylcholine is degraded by butyrylcholine esterase. Now gantacurium and CW002 is degraded by formation of an inactive cysteine adduction product and by hydrolysis. Both these products, that this cysteine adduction product as well as the hydrolysis product, both are inactive products. So your vecuronium, atracurium, cisatracurium, rocuronium have clearance rates in 3 to 6 ml per kg per minute because of multiple pathways of degradation. Pancuronium primarily undergoes elimination by the kidney, and your D-tubicurarium is independent of any organ. It is excreted because it is very long acting. So the very long acting neuromuscular blocking drugs are excreted unchanged in the urine. They do not undergo degradation by any method. So only your pancuronium, vecuronium, atracurium, cisatracurium, and rocuronium, mivacurium undergo degradation. So this is some of the metabolism of the neuromuscular blocking drugs. That is your succinylcholine, ester hydrolysis, like I said, butyrylcholine esterase. The other is your mivacurium, which undergoes uh, ester hydrolysis, that is by butyrylcholine esterase. Both are degraded by butyrylcholine esterase. DTC unchanged, excreted by urine. This is liver metabolism and renal 2, the metabolite 3 desacetylvecuronium. Pancuronium 3-hydroxy is the active metabolite, primarily renal elimination, some amount of liver 2. Rocuronium is primary liver metabolism. Rocuronium. Atracurium is Hoffman and ester hydrolysis. Cisatracurium, there is no ester hydrolysis. Now coming to the adverse effects, so the autonomic effects. So these muscle relaxants, they block muscarinic receptors in the autonomic ganglia, that is in the parasympathetic and the sympathetic ganglia, cardiac muscarinic receptors and nicotinic receptors in the neuromuscular junction. Yeah. So in the neuromuscular junction, autonomic ganglia and your cardiac muscarinic receptors. So autonomic responses are not reduced by slower injection, basically, or hypotension, and the doses are additive, that is there is no tachyphylaxis. So what happens is hypotension that occurs with these drugs can be either because of autonomic response or histamine release. So your atracurium and mivacurium are known to cause atracurium, cisat and mivacurium are known to cause histamine release. So your autonomic response, when the hypotension is due to your autonomic response, it cannot be prevented by a slower injection. So there is a dose response relationship of these dose risk relationship. So when the at more than 5, if the number is more than 5, then this is just a general, it is not very important, but if the number is more than 5, those drugs are not known to cause much autonomic, the risk is not at all there to cause autonomic responses. 3 to 4 is slight, 2 to 3 is moderate, and 1 is severe autonomic responses. Pancuronium has a number of 3. It causes some amount of tachycardia, but most of the other muscle relaxants in use non-depolarizing muscle relaxants do not cause any autonomic responses. Now, hypotension due to atracurium, like I said, atracurium and mivacurium is basically because of histamine release, because these two drugs, very important again, release histamine, atracurium and mivacurium. However, D-tuberculosin also causes histamine release, but the hypotension caused by DTC is by release of histamine and ganglion blockade, that is autonomic ganglion blockade, as well as histamine release. So DTC causes this hypotension in doses that are required for neuromuscular blockade, right? So it is dangerous because in doses that it causes blockade, it causes this adverse effect. So it is not in use. Whereas atracurium and mivacurium, only in very high doses which we do not use does it cause histamine releases. In doses that are generally used on a daily basis, even after infusion, there is no histamine release. Now, the tachycardia that is caused by pancuronium can be due to the vagolytic action of pancuronium, that is, it blocks the M2 receptors, the cardiac muscarinic receptors, and sympathetic stimulation, that is, it blocks the neuronal uptake as well as the release of epinephrine. These are the two mechanisms which can lead to tachycardia. It does not alter the cardiac output or the systemic vascular resistance. Hence, in anesthesia with opioids are known to cause bradycardia. So pancuronium is basically the drug of choice in opioid anesthesia. Like in cardiac cases, usually high doses of opioids are given. When high doses are given, side effect of opioid is bradycardia. To counteract this, pancuronium is given because of its vagolytic effect leading to tachycardia. Now, histamine release. So it is seen more often after the administration of benzyl isoquinoline class of compounds, that is your atracurium and mivacurium. It is a very short duration of action, that is 1 to 5 minutes, and it is insignificant in healthy patients. It does not usually occur in healthy patients, and it can be prevented if you inject the drug slowly, unlike with in the autonomic case. and it can be treated with antihistamines and NSAIDs, and also tachyphylaxis develops. That is, as long as the next dose is not greater than the first dose, there will be a decreased response. However, with the hypotension that occurs due to autonomic effects, there is no tachyphylaxis. So the next dose will produce the same effect as the previous dose. But in histamine release case, if the hypotension is due to histamine release, the next dose, as long as it is not greater than the first dose, will produce a lesser effect because of tachyphylaxis. Now coming to your the respiratory effects. The muscarinic cholinergic system plays an important role in regulating airway function. So M1 sympathetic control causes bronchospasms. The M2 receptors are located presynaptically. So this is your M2. They are located presynaptically at the postganglionic parasympathetic nerve ending, and this is your bronchio, right? Where your M3 is located. This is your acetylcholine which is released. So your M2 receptors are located postganglionically at the parasympathetic nerve ending, and negative feedback mechanism, that is the acetylcholine, when it binds to the M2 receptors here, it is a negative. It decreases the acetylcholine release further from the nerve ending. So M2 receptors have a negative feedback mechanism to limit the release of acetylcholine. M3 mediate contraction. So acetylcholine binds to these M3 receptors. This acetylcholine binds to M3 receptors, causing contraction, whereas the M2 receptors have a negative feedback and prevent release of acetylcholine. Hence, it controls the acetylcholine. So this causes M2 receptors basically lead to bronchodilation. So when you block the M3 receptor, now when the non-depolarizing muscle relaxant blocks the M3 receptor, it will cause bronchodilation, because the main action of the M3 receptor is bronchoconstriction. So when this is blocked, there will be bronchodilation. However, when the M2 receptor is blocked, this negative feedback mechanism is blocked. So there will be uncontrolled release of acetylcholine, which binds to the M3 receptor, leading to bronchoconstriction. So rapacuronium was binding to this M2 receptor, which led to bronchospasm. Hence, it was removed from the market. Now, allergic reactions on all non-depolarizing muscle relaxants cause non-competitive inhibition of histamine and methyl transferase, but the concentrations, it does not cause in regular concentrations, but except in the case of vecuronium. Hence, this explains the occurrence of severe bronchospasm in these patients. So, in doses that are daily used, vecuronium causes inhibition of this histamine and methyl transferase. Hence, occasionally it can cause severe bronchospasm. Very occasional, not very common. So guys, that was it for today's class, and I will sum it up briefly for you all. Non-depolarizing muscle relaxants, basically classified based on the chemical structure, steroidal, benzyl isoprenolium, and duration of action. Long-acting pancuronium, short-acting vecuronium, atracurium, cisatracurium, and short-acting mivacurium. Rocuronium is also intermediate acting. Then they are non-competitive antagonist. Only one molecule is required to bind to the alpha receptor, acetylcholine receptor, to cause blockade, and it competes with acetylcholine for blockade. And then metabolism of these drugs is basically through the kidney and the liver. The long acting is mainly through the kidney, very little amount, like for pancuronium, through the liver. The intermediate acting, like rocuronium, vecuronium, is primarily by the liver, but to some extent also by the kidney. Atracurium undergoes Hoffman's elimination and ester hydrolysis. Mivacurium undergoes the degradation by butyrylcholine esterase like succinylcholine, and also cisatracurium does not undergo ester hydrolysis. It undergoes Hoffman's elimination. And the hypotension adverse effects are hypotension and also effects on the respiratory system and allergic reactions. Hypotension can be due to because of binding of the histamine release, which is seen with atracurium and mivacurium, or due to autonomic effects. Autonomic effects are very limited. Only pancuronium shows tachycardia because of its vagolytic action. Um, and also rapacuronium was removed from the market because it bound to the M2 receptors, which mediate the negative release of feedback mechanism of the release of acetylcholine. Hence, there was unlimited acetylcholine acting on the M3 receptors, which causes bronchospasm. Hence, it was removed from the market. So guys, that's all it was. This was the first part on non-depolarizing muscle relaxants. I'll be taking my second part on it tomorrow. So guys, please hit the bell icon for notifications and use my code SASHA. Guys, subscribe fast. Get your 10% discount. Subscribe. Your 12 and 24-month subscriptions are waiting for you all. Thank you. Have a nice day.